I'm Chris Garrity, and I'm delighted to be here today with you to introduce the first episode of my new podcast series entitled Demystifying Neurodiversity. And today's topic is none other than autism spectrum disorder. So today we are going to look at autism, tell you what it is, tell you what it isn't, take a look at what's floating around in the media and what our politicians are saying, and help you sort out fact from fiction. So join me here today as we deep dive into autism. When thinking about autism, it's most helpful to think about it in terms of it being a communication disorder. It's all about communication, 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 communication. That's at the very core of the problem of autism. It's the theme that you will see permeate into all of the domains of functioning that we assess today and the handicaps that make individuals with autism suffer on a regular basis. So imagine going through life with a persistent deficit in your ability to communicate to others in a way that you really want to communicate to them in. Imagine feeling anger or frustration but not being able to communicate why. Or imagine feeling sadness or despair and not being able to add the appropriate context. If that sounds difficult, it is. And that's the reality that many individuals with autism suffer from on a regular basis. Autism is all about impaired, persistent deficits in communication. That's the hallmark of this disorder. I often hear the phrase context is for kings as a saying to convey the importance or the necessity of communicating context in everyday conversations. But imagine that being a persistent struggle. How would your life change? How would it be impaired? And how would you feel that your needs are adequately represented if you can't communicate them in a way that other people resonate with? So although we've talked about verbal deficits in communication, it's equally important to talk about the nonverbal deficits that are required to substantiate an autism diagnosis. So individuals with autism, they often don't merely struggle with conveying context, but they struggle with body language, posture, and most prominently, eye contact. And I'm not sure how many of you know this, but making eye contact for someone with autism often is not just psychologically difficult, but can be physically painful. The emotional stimulus involved can be overwhelming and can shut them down. Let's remember that autism is a neurodevelopmental disorder. It's routinely common for individuals with autism to be overloaded with sensory inputs, to not be able to process them in ways that neurotypical individuals can process them in. As a result, you can see an individual with autism frequently breaking down, frequently needing to take breaks just to process basic sensory inputs such as bright lights or loud sounds. It creates a substantial handicap in life and a substantial deficit in social functioning. Imagine walking into a crowded movie theater and the noises in your surroundings cripple you because they are simply overwhelming your ability to process them. Or imagine struggling to look at your professor or your partner in the eye and literally experiencing physical pain at the prospect of doing so. These are real situations and real implications for individuals with autism. The last domain of communication deficits that we need to talk about that is critical in substantiating an autism diagnosis is the social relationship domain. Difficulty in developing, maintaining, and understanding relationships is at the heart of autism. You may have heard the stereotypical trait of autism that individuals on the spectrum have persistent deficits in interpreting the intent of other people, understanding where others are coming from. I see this a lot in clinical practice. I see individuals with autism sharing with me the difficulty of their day because they finally realized that an individual in their life was representing something in multiple different ways to multiple different people, and they didn't understand why. And it sometimes leads individuals with autism to jump to conclusions that are not true, but are nonetheless very scary. This is what I like to call a multiplier effect in creating a handicap in social functioning. So imagine frequently going through life and straining to interpret the intent of other people and the motivations or what makes them tick. It oftentimes creates doubt about the validity or even the veracity of other people's intentions, and it can lead to shutting down and doubting oneself and one's ability to function in a world that seemingly isn't governed by rules that make sense. It can have a profound effect on someone's ability to function in all of the domains of their life, including work, home life, and friendship circles. If it's not addressed in therapy, it can become a much greater problem as a person ages. And it has a profound effect at creating trust issues on a regular basis. So, switching gears to the next domain of functional impairment in autism that needs to be present in order to substantiate a diagnosis, we come to a category of problems called restricted repetitive patterns of behavior, interests, or activities. So, as if all of the communication problems we just discussed weren't enough, individuals with autism will have at least some of these patterns of behaviors that may add an extra layer of complexity in their navigation through life. So, what do I mean by restricted or repetitive patterns of behavior? Let's look at some of the most common ones we see, and those tend to be repetitive motor movements, or what I like to call idiosyncratic gestures. For instance, you may see hand flapping or hand clapping, or the need to make certain statements, repeat certain statements. We call that echolalia. Echolalia manifests itself as repeating certain statements that are made by characters in TV shows or even maybe by colleagues or friends. And oftentimes, someone with autism can be found blurting out statements, making statements that, don't have any context to them, but nonetheless are being said. And oftentimes, these behaviors that individuals with autism engage in are soothing in some capacity to them. So, clapping their hands randomly, making statements while cleaning the house. These types of behaviors are usually something that they find comfort in to a certain extent. The next pattern of behavior that is often present is an obsession with routines or a fixed, highly inflexible way of looking at routines or deviating from routines. Routines are the best friends of autistic individuals. They create predictability in an often unpredictable world, and more times than not, deviation from these routines can cause extreme levels of distress, disproportionate levels of distress. For example, getting up every day, having the same food for breakfast at 9 a.m., checking emails exactly at 10 a.m., having the same type of food for lunch exactly at 11:30 or 12. These types of rigid routines are often present, and it's important to preserve them in individuals with autism because, again, the deviation can cause such a high degree of stress that the person can shut down in extreme circumstances. So it's best to help promote and perpetuate these routines instead of being in a position to remove them. So, what types of questions do clinicians ask patients in order to assess the presence of autism? To be clear, I'm not a clinical psychologist by training, so I don't administer neuropsych assessments for autism, but I can speak broadly about what's assessed. Oftentimes, psychologists will ask a wide array of questions, but a few common ones that are brought up more often than not tend to focus on whether or not the person has met common developmental milestones while growing up. Most importantly, did the individual start talking at a time in their life that was age appropriate, or was it delayed? Delayed speech is a major potential indicator of autism, and clinical psychologists want to explore that and decipher it. Another question that I see asked is about the presence of imaginative play, especially in youth. Not just whether it was present, but also whether it was done in connection with other children when growing up, or if it was done in an isolative way. Did the child in question only play by themselves, or did they successfully integrate their play with other individuals? Possible sign of autism is a deficit in reciprocal imaginative play. So, assessing for impairment in youth is very important because autism is present at birth. It's a neurodevelopmental disorder. And simultaneously, this is one of the reasons why adult autism assessments can be more challenging. Oftentimes, adults have trouble remembering their childhood. And if a parent or another custodian of information is not available, then clinicians have to rely on other strategies. So, other types of questions assess an individual's ability to be adaptive to changes in circumstances. Adaptivity, just like communication problems, is at the core of autism. So, maladapted coping strategies are super common. We want to see how people respond to changes in social dynamics, to changes in expectations, to changes in their environment, and clinicians will often assess a score of adaptive functioning. And they will often compare that to what we call a full scale IQ assessment, and that's an intelligence score. And I want to make a very important point is that an autistic individual's intelligence is oftentimes not related at all to their adaptive capacity or their functional capacity. So, in other words, a person can be very intelligent in many ways, yet also very maladaptive and very functionally impaired. So, imagine being brilliant, but at the same time having tremendous difficulty navigating the social environment, the social sphere of living, to a level that really handicaps you. Imagine how frustrating that can be, especially if other people demean you and assume that you're not very intelligent, even though you are. This is something that I see in my own clinical practice. So, how do we treat autism? Well, treating autism is a multifaceted and slow process. We usually don't rely on one particular type of intervention, but many. People come to me for my expert opinion in psychopharmacology and my ability to prescribe medications. Unfortunately, there isn't an approved medication for autism, but we do treat the symptoms with medication and a lot of co-occurring problems. It's very common to have co-occurring depression and anxiety problems that do respond well to medication. So there are only two medications approved by the FDA for agitation and autism for children, and those are Abilify and Risperidone. These are medications that belong to a category called atypical antipsychotics. And basically, they work by regulating both dopamine and serotonin, reducing agitation and anxiety concurrently. These medications can be particularly useful for outbursts, irritability, agitation, and similar types of symptoms. And as I said before, depression and anxiety, such as uncontrollable worry, oftentimes accompany an autistic individual's journey through life. And these are treated similarly to how they are treated in neurotypical individuals. We use SSRIs or SNRIs. You may have heard of some of these, such as Prozac, Zoloft, Lexapro, just to name a few. And they can be quite effective at treating the co occurring problems. The most effective psychosocial approaches to treating the behavior problems in the maladaptive coping and autism depends on the age at which we first intervene. In children, if we're able to intervene early, applied behavioral analysis oftentimes is the gold standard for helping kids learn to be functional. And this involves one on one instruction to help acclimate kids and reward kids for proper social skills. For instance, if Timmy with autism has difficulty with acting out in class or routinely demonstrates unwanted behaviors, a one on one coach can help instill replacement behaviors and appropriate rewards for those behaviors in order to instill more appropriate patterns of coping for that child. Other ideas include one on one coaches helping kids understand the purpose and importance of certain social and occupational graces. For adults, we use a variety of interventions, including cognitive behavioral therapy, mindfulness practices, and skills based interventions. I use a lot of cognitive behavioral therapy, or CBT, in my practice, which basically consists of open ended prompting questions to help adults think critically about the world around them. I often use emotion wheels, like the one that you see on your left here, to help adults identify and describe layers of emotions. This can be very useful in helping them articulate how they're feeling and how they navigate the world. It's really important that we spend some time talking about the myths and falsehoods associated with autism that are spreading around in the media. And the number one myth that we must address is the myth that vaccines cause autism. And let me be very clear, there is absolutely no credible scientific or medical evidence that vaccines cause autism at all. All of this can be traced back to really one specific event in 1998 when a British doctor by the name of Andrew Wakefield published a paper in a prestigious medical journal claiming a link between the MMR vaccine and autism. This was later debunked completely. He only used a small sample of 12 children and then later admitted to falsifying his own data in addition to financial conflicts of interest. Subsequent studies of hundreds of thousands of children were completed in the decade after this study was originally released, and they showed no link whatsoever between vaccines and autism. So it's really important that we clear that up. Furthermore, you'll hear a lot in the media these days about autism occurring with greater prevalence, or rates of autism are on the rise. And it's really important to distinguish between the actual naturally occurring prevalence of autism and the diagnostic prevalence of autism. There really isn't any credible evidence that clearly shows that the naturally occurring prevalence of autism has increased. But What we can say confidently is that the diagnoses or the diagnostic prevalence of autism has increased. And that's a good thing. We've broadened the diagnostic criteria over the years to include more people who were previously excluded. There's also more recognition and more reporting of diagnoses in general. There's much less stigma around getting evaluated for autism. People are more comfortable with the idea. And these are all positive social trends. But they can definitely give the illusion that autism organically is on the rise, and there's no credible scientific evidence to suggest that is really the case. In conclusion, it's important that we recognize the cycle that's important in both evaluating and treating autism. It starts from within all of us in society, that we view this as a disorder that we should destigmatize and embrace in a way that encourages people who have autism to be comfortable getting assessed, seeking help, and leaning on their community. Social awareness is key to destigmatizing the disorder and promoting confidence in individuals who have it. Ultimately, this leads to a greater sense of contentment and ultimately a better quality of life for those who have autism and for those who care for them. So, thank you very much for listening to my first episode of my new podcast series, Demystifying Neurodiversity. I look forward to talking with all of you again next week as we deep dive on another topic of neurodiversity. But until then, stay safe and be well.